should do a competition. Okay, Cody. 10 seconds, okay?
Oh, that's all we get is 10 seconds?
Are you making the logo?
Yeah, we're gonna do a... Oh, don't give him ideas. Okay, 10 seconds, okay?
I need to see my logo.
No. That's not... You're Cody, he gave me the wrong one. It's okay, I'll fix it. Where is yours? Mine is much better. Like, so much better. I'll win. I want an Instagram poll.
I want an Instagram.
Lucy! Instagram poll it is. Come on.
Do you want me to do one for you?
Oh, look.
And a perfect FenVet logo and a little meaty treat.
Oh, that's a FenVet logo.
Oh, come on.
Mine was better.
Yours was excellent.
Oh, hello. We did a competition on who could do a better lick match, and I think I won. You can. Which one's mine? Better one. Is this for Mabel? No, this is yours, Lucy. Look how beautiful. She doesn't like it. Lucy. Here, there. That's yours, Mabel.
So when we saw him walk in the first time, Nicole like ran out because it looked like it was broken. So we thought he was like running in on a broken leg. So Nicole blasts out. She's like, "Do you need me to hold him?" And they're like, "No, this is how he is." So he is a rescue and he had nerve paralysis. So that's why he's not placing his foot. So there's no break or anything. He had an injury somewhere, maybe his radial nerve, but he essentially cannot place and has minimal sensation on this leg. The original plan from the rescue veterinarian was to keep him in a brace, but he did not tolerate that well at all. And just as time progressed, then he started getting some lesions, and then those lesions got infected. So the owner, under our advice, selected for amputation. So we're gonna be a tripod right away, and we're a great candidate. We're a good breed, we're young. It's a great case. Yes, it's a great case. I know. You're gonna heal just fine. He's a rescue, so we don't know his history. If he got in a fight, if he got ran over, if he got caught in a trap. Like we have no idea why he would have got the nerve damage he did. Some sort of trauma, and then that caused the nerve damage. Sometimes we'll wait to see if there's some regeneration of those nerves and get at least partial return of function, but in this case there must be severe enough nerve damage that he's just not responding to time and healing. So, and it's getting worse and worse, so it's got to come off.
We're inducing him for surgery, so just putting an IV in. We'll hook him up to fluids in a minute.
I'm going to try to do a brachial plexus block. They don't work all the time, but sometimes they do work. We just don't have a good way of trying to block other than doing a splash block in surgery. So I do try to freeze the area prior to. So somewhere underneath the scapula, there's the brachial plexus, which is a bundle of nerves that shoots off to innervate the rest of the nerves in the limb. So I'm just going to put my needle in and I'm just going to fan. So hopefully we block some of it so he doesn't feel as much, but really he can't feel anything in his limb as it is. I also never get a helper, so this is nice.
You're like, oh, I don't.
Yeah, I don't have to hold.
I was like sitting everything on by her.
No, it's not. It's just because that's what I'm used to. So there's a couple different ways that you can do a forelimb amputation. Prior to sedating him, we kind of did another neuro exam to see where he was feeling stuff. He doesn't feel anything. Like, we would say that this is distal to the elbow, but up here he does feel some, and then he does for sure start to feel on his shoulder again. So we could go, this is the humerus running right here. So we could go mid-humeral, we could go like at the scapulo-humeral joint, or you could take the full scapula, which takes like the entire shoulder. I typically like to go at the shoulder, just my preference and what I'm used to. I should just probably learn how to do the shoulder one too. It's just now I'm comfortable with this surgery, so I always just do it this way. There's no reason that we couldn't go mid-humeral. The only reason I don't want to is I don't really want to cut the bone in half. So if we go mid-humeral, then we have to saw the bone, whereas at least this way, at the scapulohumeral joint, I just disarticulate the joint and then I can take the whole leg away. I find every time I do this, I thankfully have usually too much skin. Yeah, thank you. Versus the alternative, not having enough skin to work with. We'll start just dissecting through muscles. I'm pretty aggressive with my surgeries, but still you want to make sure that you're clamping your bleeders. Flip up. I'm just like, if you see any massive bleeders, let me know. But right now we're doing pretty good for bleeding.
Yeah. Right where you're by like that pivotal joint there where everything is gonna connect.
Exactly. Ready? That's gone. Sorry. You missed it. This is called the glenoid fossa. And we're going to scrape it because we want it to stop producing joint fluid since there's no joint there. Trying to just remove those superficial cells so that it doesn't.
So because you don't have anything to lubricate to move anymore.
We don't need it there. And then now we're going to close everything. If there is a ton of tension, we can use certain patterns that help with tension. Often I like to use like a horizontal mattress pattern, and that will help relieve some of the tension so the suture doesn't just like rip through.
So instead of just going like 1 inch across, you actually kind of almost make a little bit of like, kind of think of how your shoes are. And so yeah, if one side goes, it can like evenly distribute a little bit.
I don't have that much tension though, so it's, I don't have to for this. So I'm trying to close like the muscles that run diagonal together and then the ones that run over top together. So it's not just like a meaty thing together. So hopefully the muscle fibers kind of run in the same direction. As you can see, it's closing all really nicely. Like there's not a ton of tension. Everything is coming together really good. So now we're just gonna close our sub-Q and then our skin and then we're done.
When she started on the leg higher up with her first cut, it gave her extra skin, so now she's just trimming down the extra she has to the size that she wants to be able to close the way that she'd like it to.
I mean, a good problem to have at least. I'd rather have extra than not enough. Now we're just going to see where there needs to be extra sutures. I'm just going to clean up this mess.
This kitty has a pretty bad restorative lesion, what we suspect is a restorative lesion. It's pretty much her own, like the bone started to restore the root of the tooth. As you can see, there's no root. Like here, this is a root. There's no root there in the mandible and just the crown. So what I'm gonna do right now is I am going to amputate the crown, and because it looks quite angry, which could be normal of a restorative lesion. We're gonna amputate this, but I'm also gonna take a biopsy of the bone and make sure that there's nothing worse than just a restorative lesion. This is very painful. You can see that the inside of the tooth is exposed, and that's really, really painful in kitties. So that's what we're gonna be doing right now. Yeah, I'm not gonna say common, but it's, you know, oral tumors are a thing. She's 9 years old, so I think is the best to make sure that we're not leaving anything. Like if there is cancer, we'll diagnose it. If it's an infection, we're gonna take care of it. Because it just looks on x-rays a little bit angry. So then what I do is I just go with this little small tool and I go as deep as I can, kind of crunch the bone a little bit, and I'll send that out for a biopsy. But I think this one is one that I will keep. I wouldn't amputate the crown yet because there hasn't been a resorption like all the way in. Yeah, so this is complicated. Let me just see what Carlin will do on this one because I don't think it's deep enough.
White is the most dense, so that's your bone, and that's why we can see this on here. The black spot within the tooth is where it's less dense, so that's where the lesion would be.
Will you try to extract it or frown out?
That I feel like you have to extract because there's no resorption of the roots.
The x-ray, it's not too bad, so I would just probably clean that really, really well and leave it there for now. Okay,
Try to save some teeth.
This is a flap, a gingival flap, so I make room so I can see the bone. This is a tooth that is pretty deep in there, so I'll have to burr the bone, like so, kind of shave the bone off so I can see the roots, and then I can actually extract it. We're gonna break the cement of the tooth to get a little bit of mobility, which I'm starting to get. And there we go. Yay! Good.
Textbook.
Jody's gonna take an x-ray, make sure that we didn't leave any roots.
Beauty.
Okay. Yay! Success! You can see how the dental disease like goes all the way there. It was covered by gum. That's why those cleanings, those dental cleanings with no anesthesia and stuff, like they're missed a lot. So why am I doing it? Is because when we, you know, she came in for a dental cleaning and extractions and whatnot, and when we probed the tooth, we realized that there was a space between the gum and the tooth that goes quite deep, and that gives us indication that there is detachment issues, like the gum and the tooth and the bone are not as attached as they should be. It's tight. And so when we took the x-ray, we confirmed that there's bone loss, and then that is what we call periodontal disease. It's just pretty much that inflammation of those tissues, and once that happens, the tooth gets affected and it has to come out. If we had left this tooth there, which, you know, sometimes if we didn't have x-rays, we couldn't know that this is what's happening. So if we left that tooth there, we'll just still keep losing the attachment until it gets infected and then becomes a bigger issue. And once I have a better visual of what I'm doing, then I'll try to, you know, make that. Even now there's a little bit of mobility, so then I can extract it to prevent that from breaking. And then I'll just suture it, and then that's it. We're good. No big deal. Dental in a cast with extractions in front of the camera. Frick. I'm going to have something to drink later.
That's essentially it for this, and then there's just a little lump to take off her tail.
It's just sebaceous material. So there are glands on the skin, like in the skin, that produce that sebum, and they just get overproductive. Now we're gonna close her up.
So we're just wrapping up our morning surgeries. So Finley, the amputation, is recovering now. He's up and awake. I was just giving him some love.
Finally get your cone off. Go for a run.
And the rest of the day is just going to be medical appointments. Dr. Mel is not in today. She is on vacation, so a couple days of rest for her. And yeah, it's just been a busy day. I'm very thankful that Dr. Yolanda came in to check things out with us and keep us on track. It's always a pleasure when Dr. Yolo is in the house.